we're going to look at dosing, and then we'll get into the cases pretty quickly on the tail end of this. So I think, you know, in my experience, this is probably the one area where people, after they start doing VNS, have more questions than anything. Is about how do I dose this? How do I, you know, which one do I change? What does this do? What does that do? This seems to be, you know, it's just a lot of variables, and I think it takes a little bit of time to kind of feel comfortable with all, but where a lot of questions are generated. So hopefully, if I do my job, I'll cover it in a way to answer a lot of your questions, but if you have some, if I don't, be sure we get to those as well. And I think the way, you know, we explain it to patients, I have to like the term dosing, because when the device first came out, we talked a lot about programming the device and programming patients, but patients don't like the word program. So think about telling you you're programming, you know, just they don't like it, doesn't sound good. So dosing is a good way to think about it. And when we talk to patients, I mean, just like when we, you know, start a new medicine, if I was going to tell you that, you know, as an adolescent that you were starting on, you know, pick a drug, topiramate, and said, you know, what would you need to do with the dose? Where, you know, what would you work it up to say you gave it a fair chance for their seizures? You know, what range would you like to see it in? If they're tolerating it okay, you could probably tell me, okay, this is, you know, I'd like to have them up to, you know, 100 milligrams, 200, whatever you would say, you know, if they're tolerating it, so I can see if it works or not. And I tell families, you know, the device is just like that. We have to slowly increase it to a certain dose range. And once we're there, then we can see, you know, if it's, you know, kind of how it's helping you. But we have to, you know, get it there. And now we have good data that kind of tells us, you know, what does that range, you know, need to be and where should we be. So I use, when I talk to families, I use a lot of, I guess, medicine analogies, because I think they understand that. So we talk about, you know, increasing the strength, which is the dose of the device. You know, the on-off time, we kind of say it's like, you know, your medicine, some you take twice a day, some once, some 3 times a day. It's kind of how often during the day, you know, do you get it? So I think that helps them kind of understand it a little bit. But just like medicines, I mean, any medicine we start, we want to kind of maximize how well the medicine works, and we want to minimize side effects. And the same exact thing is true with the device. We want to kind of maximize how it works, and we don't want them to have any side effects. So it's very true. The key is, since we're dealing, as I talked about a little bit before, but with a nerve, and we've got to activate kind of fibers in that nerve and generate action potentials, we've got to get to kind of a certain minimum charge, so we can activate enough fibers to do that. And I think the minimum really is probably this 1.5, and I'll show you some data around that. Probably 1.5 milliamps, and I would say at 250 even, I think is a good minimum. Here, and I've written it down over here. I would never use 500 if you can help it. I don't know of any reason to use this at 500 other than it's in the label, but I mean, I know of no medical reason to use it. It just happens to be in the label. And this is no different than any medicines. I mean, the medicine label for, you know, topiramate, again, says you're supposed to go up to 400 milligrams a day for monotherapy. Well, none of us do that, right? For monotherapy. We seldom go beyond 100 or 200 milligrams a day. So in medicines, we're very comfortable ignoring the labels, so I think here we just have to be as comfortable, because it was started many years ago when we thought that was, you know, a quote-unquote good setting. We now know it's not a good setting for patients. They have far more side effects, and it doesn't improve their efficacy. And if you use 500 instead of 250, you'll also use about a year of battery life you'll lose as well, too. So you gain a lot of battery by not using the setting as well. So I would encourage you to do that. And I would stick with 20 hertz also. I know of no reason from an efficacy standpoint to use 30. You also gain battery by using 20 instead of 30. And again, patients tolerate it wonderfully. So much, much better. But I think you have to get to those kind of minimum points to say that I've given it a fair chance. And, you know, if we look at, you know, non-responders to vagus nerve stimulation, I mean, there are obviously patients that it doesn't work for everybody, just like, you know, we don't have a medicine that works for everybody. But if you look at, you know, other than the patients it just didn't work for, the next big group of non-responders is people that they never got up to a fair dose. They were always too low. So again, just like in medicine, if you start them on it and you're too low, it's probably not going to work as good. So you have to give it a fair chance and get it up to dose, and that's a big reason for non-responders. So what do we mean when we talk about the dose? So this is to try and kind of show this in graphic form. So if when we stimulate, you know, we have a pulse, we're stimulating. If our dose is not up high enough that we're generating any action potentials in the vagus nerve, we don't ever kind of, you know, hit threshold with our charge, you know, then nothing happens. So we've got to have our current up enough to generate enough charge. We get a little better here, still nothing, happens to finally get an action potential. Remember, this is kind of an all or none thing. We've got to get our action potentials in the vagus nerve to get to the brainstem to have the device work. So that's why we have to kind of have a certain, minimum charge to get there. And remember, in this case, it's the A and the B fibers we're trying to, activate. So if we look at each of these variables, some are pretty easy. So the milliamp is, I would really think of as the dose. I mean, this is probably the most important factor in kind of the using the device and getting it up to where it needs to be. And like I said, the target range, I think 1 is a little low. There are rare patients that will respond at 1 on the adult side mainly, but they're uncommon, just like there are rare patients that, on a relatively low dose of medicine, they do great, but not most. So I think for most adults, you probably got it between 1.5 and 2 is the range. I think children, you probably have to be 0.25 to 0.5 higher. Some of that has to do with developmental changes in the brainstem. Some is just the difference in the vagus nerve changes as well too. So I think it's a little bit higher than this. The pulse width, is interesting because you would think, if you have a pulse width of 250, when you go to 500, that you double so that it's on, a longer time. You would think that would be better, you would generate more, but when you look at kind of a charge density curve, the actual charge to the nerve is a combination of the pulse width and the output current, and the output current really drives that more between these two. So you really don't generate more current with standard outputs at 500 than you do at 250. Like I said, you get a whole lot more side effects. So I would start at 250 rather than waiting until my patient has problems, because the reality is, if you start at 500, as you go up on the intensity, almost every patient has problems. So there's no point in kind of saying, oh, wait till you have a problem when you know they're going to have a problem. You might as well just do 250 to begin with and then avoid it, and your patients will be happy. And even the adolescents and adults that come in at 530, and you say, how are you doing? Do you ever have any problems with your vagus nerve stimulator? Do you ever have coarse, tickle your throat, hoarseness, cough, and they'll say, oh no, I'm doing fine. And then you change it to 250 and 20, and they go, oh, I feel better. And you go, wait a minute, you just said you were doing fine, and they were in their mind, but they didn't realize that, oh, now I even feel better, I didn't even notice it. So I would still do it even in those patients who say that they're fine. The frequency, obviously, is how often it comes on in a second. And like I said, you might guess, intuitively, this might seem like 30 hertz is better because it's coming on 50% more than 20 hertz. But there's no data to show that the efficacy is any better with 20 hertz, with 30 hertz than 20 hertz, and the side effect profile is worse, and you use a little more battery as well. If you go to really high stimulation with peripheral nerve, with vagus nerve, like 50 or 60 hertz, that's probably definitely you get far more side effects. And if you go really low, if you go to 10 hertz, 5 hertz, it's not clear that yours is efficacious. So this seems to be kind of that happy midway point, if you will, which is very different than intracranial stimulation, right? That's usually very high, 150, 200 hertz. So it's very different intracranially versus peripheral stimulation. All right, so if we try and put all these together, it's a challenge. So remember, when the device comes on, we have our on time, kind of our off time. There's this ramp up before the device comes on, just so it's otherwise it'd be like a quick on that the patient might feel it, it'd be kind of like throwing the light switch, boom, going from dark to bright light. So there's just this ramp up over 2 seconds to make it easier for the patient to adjust so they don't kind of feel it, and then there's the ramp down. I've never been clear why there's a ramp down, because that I wouldn't think you'd feel, but there is. Just the way the engineers designed it. And then obviously whatever the off time, then this repeats and kind of just keeps going with a life of its own all day long, right? As well. All right, so there's a zillion parameters you can set for this. And actually, I always tell people that if the device came out, now instead of when it came out, I think there would only be about 10 or 11 or 12 parameters. I think that in hindsight, the company realized there's probably way too many, and a lot of them were never used. So I think at the time they didn't know when the device first came out which ones would be used more or not. But so we have them, but probably most of them we shouldn't use. The output current, like I said, I would just raise this bottom limit and say it's probably got to be 1.5 to 2. Kids a little bit higher. I would stick with 20 hertz here and 250 here, and then these are standard on-off times to start with. as well. And I think if you start there and then start working on your output current, this one is going to be 0 to begin with, and start slowly building it up, that should be the main kind of change you're making, if you will, when you're following the patients initially. And then only down the road would you look at changing the duty cycle or kind of the on and off time. But the main one, at least initially, should all be driven by the current. That's the most important factor probably for efficacy. And this gets into this a little bit. So if we look at the actual nerve, and these question marks have actually now been answered a little bit, because the company that sends this slide and this reference has done a nice study, and I think there's a copy of it out there, that's a simulation study. So you can actually look at autopsy specimens of vagus nerves, and then you can go through electron microscopy. You can say, okay, how many A and B fibers are in the nerve, and where are they? Because they're not all in the middle, some are on the outside, and they're in fascicles. So you have to kind of figure out, okay, how much connective tissue is here, how much fat, how much connective tissue is here, and if I'm trying to stimulate this nerve way in there, you know, how much charge do I have to kind of drive into the nerve from the outside, because there are wires on the outside to stimulate those fibers. And then you can do kind of mathematical modeling that I can't do it, but the electrical engineers can do it, and look at what charge density you need, because the wires on the outside, it's kind of the blue here you see represented, to drive that current into the nerve. It never goes all the way around. It's like a phone cord kind of wrapped, the thing, and there's always a little bit of a space. You can see it represented here, that it's not all the way around if you do a cross section of the nerve, okay? So it's always, you know, you're driving current in this way, this way, this way, this way. It's harder to hit these two fibers here because there's not wire right over it. You're kind of having to go in this way. But that's where the more current ideas about what minimum current you need to have to hit the A and B fibers has come from, because you can figure out, you know, what current you have to stimulate them and to get action potentials, okay? So this is what's really kind of driven all that. So obviously when we start the device, you know, we want to make sure the generator is even working. I have to admit, we always check this, but having put a lot of these in, I've never come across a dud yet. Hopefully won't. The company has a ton of you know, checks on them before they leave them, so it would be odd, but I guess possible, right? That you would get a generator interrogated and it'd be brand new. And I mean, I've never had it happen, so if that happens to you, you really have bad luck, okay? But obviously you want to make sure it's good, so you interrogate just to make sure it's functioning and it's good, you know, as well. You know, then you start to program in, obviously, the parameters that you're going to use as well. And like I said, initial parameters, you know, you start, you know, you're 0, so you turn on to 0.25, 30 seconds and 5 minutes off is fine. I would be 20 here and 250 here. In the original studies for every device, in the studies, the device is always implanted, and then you always wait before you turn them on with every device we have. And the whole reason you do that is because when we first started doing the studies, the surgeons correctly said, well, wait a minute, if you turn it on in the OR, then if the patient has a problem, I'm going to get blamed. Even if it's from the device, because it happened right after the operating room. So the surgeons were smart about that, so you can't, in the studies, you can't turn any of them on. So all the studies always have the device going in, it's left off, and then you wait, make sure that, you know, there's no, you know, perioperative problems, and then you turn them on. But that doesn't mean you have to do it in real life. The studies were just done that way, so you could tell, you know, what side effects were the device and what was due to the surgery. In real life, you could start. I mean, there's no reason not to as well. So it depends on your situation. If you're at the hospital or your surgeon is comfortable turning it on, they can turn it on there. If the surgeon either wants you to turn it on and you're not there, you say, I want to see it back in my office, that's fine too, waiting, you know. And somebody who's had intractable epilepsy for, you know, 8, 9, 10, 20 years, to wait a week or two is really not a huge issue. So, you know, there's no problem either way, just whatever works for your system to do it. And then, you know, the ramping up depends a lot on your situation too, is, you know, how quick you go up, you know, how often are the patient's seizures, and a lot of other factors. So you can, you know, kind of the standard practice is probably to do it every, you know, 2 to 4 weeks or so initially till you get up to the minimum dose, and that's fine. But again, just like in medicine, you know, if someone's tolerating it, you can go quicker, right? I mean, as long as they're tolerating, there's no reason you can't. So it's no difference with this. If they're tolerating, you can go as quick as the patient will tolerate. There's no, you know, downside to that. So we will occasionally do that for patients that live a long distance away, and you may have this come up just because this sounds like the practices I've heard about here. We have a kind of, it's like a nice hotel but across the street from the hospital where the patients can stay for free. So if we have patients come from a long distance, they'll get the device put in. We may turn it on in the operating room, 0.25. They'll go to the hotel. The next day we may see them in clinic and turn it to 0.5. They may come back the next day and go to 0.75. The next day and go up to 1. So we may literally go up every day. So if they stay a week, by the time they go home, it's already at 1.5. They're already at minimum dose. In kids, you can usually do that. In adults, it's much tougher. By the time you get to older adolescents, adults, you may have to go every other day, kind of up there. Just the tolerability is not as good. But as long as they're tolerating it, again, you're just trying to get to that minimum dose, so there's no downside. Just like if you're going up on, Keppra, if you go really quick, as long as they're tolerating to get the minimum dose, there's no harm. It's just that they don't tolerate it, you have to go slower. So it's the same thing. So if you have patients from a long ways off, sometimes that's helpful because if they have to come back and see you to get, turned up to 0.5 and travel a long way back and come back, even if somebody's paying for their travel or everything, it's just, they may not come just because it's inconvenient to come every 2 or 4 weeks. And if you can do it, then at least when you send them home, if they can't come back for 6 months, at least it's on and should be helping them some. So it's worth, I think, keeping about it if you have that option for your patients. Because if you can push them, that's fine. There's no downside to it. And then typical adjustments, and again, if you're doing it kind of over time, as we talked about, you're mainly adjusting the output current, so you're going up, 0.25, kind of one step at a time, if you will, and then this is, obviously a few visits between here, but just to give you a sense for that, to get to this kind of minimum dose. The magnet's interesting, because at the low end, we usually set it a little bit higher, with the idea being that if we really need a 1.5 minimum dose, the patient's regular current is not that high, and this is still not that high, but it's at least a little bit closer, and we hope that if the patient's having a seizure, they'll tolerate the higher current because, they may be partially in their seizure or not as aware, so they may not cough, it may not bother them, but we're trying to capture those other fibers as well. Once they get up to full dose, the main reason we set it higher in adults is they can check themselves. Because we'll have some adults and some teenagers that will say, I don't feel my stimulation anymore. And if they don't feel it, the first thing they assume is it's not working, right? The battery's dead or there's a problem, because they've been feeling it all along. And they've really just kind of gotten adjusted, if you will, the stimulation or acclimated to it. So they can swipe themselves, when they're not having a seizure. The magnet's a little bit higher, and then usually if it's 0.25 above, they'll feel it, and they can kind of check themselves, if you will, and know it's working as well. So that's the main reason. If you have say a cognitively impaired adolescent that can't tell you they feel it, then you may not set it higher. You may set it the same once you get up to full dose, not at the lower end. Okay, because that's the main reason to have it higher. So it depends, again, a little bit on the patient and how you handle that, okay? In young children that either can't talk because they're nonverbal or again, they're cognitively impaired, once they're full dose, there's probably not a real good reason to set the magnet higher, because if you're full dose and you're already, stimulating all the A and B fibers, generating action potentials, then to have it set higher, you can't generate any more, so, it's not going to change anything. So just think about that. The low end, it makes sense, but once you get to full dose, you may want to set it the same as well. The other thing, this came up earlier today, I think, too, but about, the magnet working or not working. So if families leave the hospital here, and after a week or two they say, oh, I'm using the magnet, it's not working. Well, of course, because it's only at 0.5, right? So it's probably not up to full dose either, so it's not going to work. So so you have to remind families that, wait till you get up closer to full dose, and then, because if they go slowly to get there, if it takes 4 or 5 or 6 months to get them up to 1.5, if they've had 4 or 5 months of saying, gosh, I tried the magnet and it didn't work because they were at low doses, then they probably say, I don't want to mess with it anymore. I've been using it for 3 or 4 months and nothing happened. So some of those families you have to kind of remind and say, listen, you weren't at full dose before, now you are, try the magnet again and see. Okay, so I would, if they say it works, obviously that's fine, but if they say it doesn't work, I would remind them of that. And then the other thing that we do is once they say we're full dose and they're working, is we ask them on their seizure diary to just put a sign or write M or something by the ones they use the magnet, because then when they come back in the office, we can interrogate the device and it lists the last 15 magnet activations. So we can look and see, because we have some families that come back and say, it's not working, we tried it, and then we look at their calendar to look at the dates, and then we open the magnet activations, and there's not a single one. They missed it every time. So we say, okay, it's not the magnet's not working, we just have to re-show you how to do this because you thought you were swiping it and you missed it, every time. So we have them actually swipe it in front of us in clinic, look at how they're doing it. We can re-interrogate and see if it registered, and if it didn't, we try and kind of figure out how we have to, modify it so they do it. That's probably the only other time it's important for the surgeon too, because we've actually had some patients that when they first start their seizures, if you use a kind of subpectoralis approach, that they'll internally rotate their arms like this. Well, if they do that, then you can't swipe with the magnet. So in those patients, we've had the surgeons actually kind of do a more diagonal approach below the clavicle so the family could actually get to the thing. So we think a little bit about their seizures. That's rare. Most of the time if they're just staring off with a partial seizure or if they're convulsing their arms right here, then you can get to it. But once in a while that comes up. So we do think about that if we have somebody whose arm comes in with their seizure and talk to the surgeon just to say, okay, should we change where we put it so the family can actually use the magnet, function on the device. All right, oops, I didn't realize that highlighted my slides. There we go. All right, and we've talked about, even if families do wonderfully, when the device first came out, we didn't have the kind of some of the modeling to know how high we could go. And the maximum setting is 3.5. So adults, you could never get to 3.5. They would complain. I mean, you couldn't get above maybe the 2.75 probably. But we had some, even, 8, 9, 10, 11, 12-year-olds that you could push all the way up to 3.5, and they would say, I don't even feel it. And you go, really? You should be feeling it. They said, I don't even feel it. So now I think the one thing we learned is we don't need to do that because we were just wasting battery because we'd already captured all the fibers, and so we don't go that high. But if you do go higher, you're going to get side effects, and you're probably not going to get any more improvement in seizure control with it. So the first thing, like I said, is you should be kind of going up on the intensity. I would probably sit there for a while, literally 6, 9 months, maybe even a year, some people would say, when you first done that. And then after that, if you think, okay, I may be some better, but not as good as I would like, that's when I would think about adjusting the duty cycle. But the intensity really should be your main kind of thrust, if you will, not the duty cycle. And the duty cycle is just this combination of how often is the device on, how often is it off. And the standard one is about 10% if you think about it, with kind of the 30 seconds and 5 minutes. So this is kind of the table. So this is the standard one, 30 seconds and 5 minutes, and this is just all the duty cycles. So usually when you increase the duty cycle, kind of the easy way to do it is kind of change the off time from 5 minutes to 3 minutes, then from 3, to 1.8. Some people even go 1.1. What we don't know though, which is to me I think interesting, if you look, let's see if I can find two that match up pretty good. This is a 41% duty cycle, right? 14 seconds off and half a minute on. Okay, this is almost the same, 38%, and this is a minute on and 1.8 minutes off. So they're very different timing with almost the same duty cycle. So you think, okay, if they're the same duty cycle kind of, but very different approaches, does it make any difference how you get there? We have no idea. Even in animals, that's not been looked at that I know of. So we tend not to do that. But the one thing we kind of all agree, we all agree on, I guess, is we try and avoid over a 50% duty cycle. So the area kind of in red here, which this is why I said that if the company came out today, they wouldn't even give you these choices because they tell you not to go there, but yet it's a choice. It's kind of like putting out the ice cream dessert for me at lunch today, but telling me not to eat it. I just can't help it. I have to go eat it, So it's not fair, right? So they shouldn't even really be there if you're not supposed to use it, that kind of thing. But they are. So, but don't go above 50%. It's probably more theoretical than real. But if you were really high, more than 50%, you could hurt the nerve. That's probably not the real. Probably the practical aspect, if you go beyond 50%, is your battery won't last long at all. I mean, that's probably the more realistic one from a practical standpoint. The other duty cycle that gets used is, other than just shortening this, is we will sometimes do what's called a rapid kind of duty cycle, where we do 7 seconds off and usually 0.3 for our off time. So it's a very quick, it's coming on, a couple times a minute, kind of spinning around as well. It's interesting, if you look at animal data, guess what the most effective is in animals for stimulation in the animal model? Anybody know? It's on all the time. We obviously can't do that in humans because the battery, you'd be changing battery every 6 months. Your surgeon would be like, I can't take it anymore, stop. You know, I can't do all these, you know, so it's not practical. Plus you probably, you know, wouldn't tolerate, you'd be getting a lot of nerve stimulation. So we can't do them with, in animals is the most effective. So that's how we got to this on-off to begin with, you know, as well. We also got to the on-off because in animals, when they realized you couldn't do on, people looked at, is there a kind of a carryover effect from the on time? In the animal studies, there does seem to be a carryover effect. So in other words, you can, you know, turn it on, wait till it goes off, and then stimulate for a seizure. And if you do it right afterwards or within a time window afterwards, you're less likely to start a seizure than if you wait further to do it. So there's this kind of carryover effect too that alters kind of the threshold. So that's the other kind of combined reason. But this is the area that probably that there's the least data on what's the best to do. So I always tell people, you know, if you start with the standard, you can shorten this, go down to maybe 1.8. If that doesn't work, you can try it very rapid and just switch over to here. If there's no difference between any of them, then I would go back to whichever one was your best over here because that preserves the battery life. So you can try the other ones, but it's just like if you go way up on medicine, the patient says, well, you know, when you went up, you know, to 200 a day, doctor, the titration improved my seizure control, but when you went to 250 or 300 or 350, the seizures didn't get any better, and I just had more side effects. So you probably, okay, we're going to go back down to 200. So the same with the device. If you try different duty cycles, if they're better, great, but if they're no better, I just go back to kind of where you started. And you have to kind of remember that, which is why it's important to give enough time on each duty cycle so you can tell. And I would say at least usually 3 to 4 months. Sometimes you need more time so you can figure that out. All right, we've kind of gone through kind of the options here as well. All right, so this is kind of just walking through the duty cycle, kind of doing these slowly, which we've kind of talked about here. All right, the magnet. So, so the magnet we talked about a lot, kind of just, you know, when to use it and to reassess kind of the efficacy of it after the, you know, the patient's up to effective dose. We talked earlier this morning about, you know, if they need an off switch, this is their off switch. Important to remind families of that. And then the other thing I would mention on the magnet, so the current, you know, at the beginning I would set it, you know, when they're low, you could set it a little bit higher. You know, as they get up to kind of therapeutic stimulation, you can make some decisions depending on if they can, you know, tell you when they feel it or not. I always set the magnet pulse width at 252. This should always be at 252. There's no reason for this to be at 500. 250 is fine. And then the on time, I always set it about 14 seconds. There's no reason for it to be a 60-second on time. Because you think about it, you know, what's the average length of duration for a typical complex partial seizure in an adolescent or adult? 60 seconds, right? So if they feel their aura, think about getting their magnet out, get their magnet out. By the time they swipe it, at least 15 or 20 seconds have gone by. So then if you swipe it, you say, okay, another 60 seconds. Well, the seizure is going to be over before the magnet, you know, finishes. So you clearly don't need that much time because the seizure would just stop on its own normally. And then the other thing, remember we talked about this morning, but if you swipe the, you know, hit the switch for the signal to travel from, you know, the generator along the wire to the nerve and then up to the brain is literally a fraction of a second. So you don't need, you know, 60 seconds to go from here to here. I mean, the nervous system is much quicker than that, right? So you really only need a few seconds of time. So we always just set our 14 seconds. It saves battery, but the other thing it does is what happens when people use the magnet, you know, whether it's an adult and it's the spouse or if it's a parent using it on a child, you know, what happens probably half the time? They miss the device, right? Because the person's seizing, they're twitching, and they're trying to swipe it. So if it's 14, if they miss it, you just say, do it again. You had to hurry then. I mean, even if they got it before, you just added 14 seconds to part of 14 seconds, so it's still a short, you know, on time, and it's not like you've added 60 seconds to something for this really long stimulation. And a lot of parents will tell you that they're not sure if they got it the first time, and even a lot of spouses because the person's moved or they're just excited, you know, because they're seizing in a minute. So, yeah, that's the other advantage of the short time, too. People say, you know, if you're not sure if you got it, just do it again. And you can check that, obviously, when you see them back, too, from their magnet history. You know, you can say, yeah, you actually did get it, because I saw like 5 in a row right back to back. You know, so, as well. And as we said before, obviously, you know, their tolerability is what's going to drive the dose. If you do the 250 and 20, they will tolerate it the best. I can guarantee you that, though. But we'll talk about this. So that gets rid of the side effects. If you do that and they're still having problems, then obviously you're stuck going down the dose. Rare patients, if you do that, you may have to go from 250 down to 130, which is the next step down. Those are uncommon, they're almost all adults, you can almost guarantee it almost never happens in kids. And if you have to do that, at some point down the road, you may have to wait 4 or 6 months. I would try and get it back to 250, because at 130, you're just gonna not deliver near as effective a stimulation. So try and get it back if you can. All right, and then end of service. This is what you wanna avoid, right? So you really don't wanna wait till the generator goes to 0 if it's working, just like you wouldn't with a cardiac pacemaker, obviously. If it's, if it's doing what it's supposed to be doing, you don't want the battery to go to end of service and then have to start all over. For several reasons. Some patients' seizures will get dramatically worse, as we heard this morning. There are some folks that when you have to start back over, instead of just being quick to go back up, it's a very slow process, which is also painful if they live a long ways away, or just you'd have to redo all the visits over again. So you can check and see the different generator models have different indicators. The new ones are actually nice because there's a little kind of battery icon, so it's a lot like a gas tank. You can tell if you're full or 3/4 full or half, or like if the red light's on, it's kind of like your car. You're about to, you better find a gas station soon or you're stranded. It's the same thing, with the device. So that actually makes it a lot easier. The old ones just gave you a yes no, which wasn't as convenient. We always tell families, when it gets close to the end, I mean, if you're doing well, it's just like, in your car, if the gas light's on, it's not really worth stretching it to say, okay, maybe I can drive another 20 miles before you get gas, because if you're off, you're gonna be walking, right? So it's just not worth it, you might as well so we tell them the same thing, gosh, if you're that close, let's just schedule you and get this done, because it's working. We really don't want you to run out, and even if it's 2 or 3 months worth of battery, over 8, 10 years, it's not worth it. You're better off just getting done and get the other one changed. And if you do it before it goes to end of service, in the operating room, you can just go, you interrogate the old generator you've taken out, make sure the settings are the same ones you thought they were, and you can just program the new one the same exact settings, to start all over. So it's kind of like, a race car doing a quick, tire change in the pits. So literally to replace a generator, if that's all you have to do here is, the paperwork is far more than the surgery, right? It's like a 5-10 minute surgery, and the paperwork is an hour, so. It's more painful, I think, for the surgeon because of that. So it's a quick, easy surgery, but you can just kind of go right to the same ones. All right, so we've talked about, basic things, but I think the real key for effectiveness, and especially when you first, are kind of getting your feet wet, if you will, with vagus nerve stimulation, is just stick with the intensity and go up with that. And like I've written here, stay at 250 and 20 and work on your intensity, then you'll have the best success just kind of doing that, getting that in the minimum range. And then you can always do the duty cycle stuff later. All right, I think we're about done. Let me see, we did that, Okay, make sure I told you everything I was supposed to. Yeah, obviously make sure your wand's working. If the battery's dead in the wand, you won't be able to do anything, right? You're gonna walk through that, I guess, as well. Troubleshooting, you're like hit them with a wand, right? As well. The 9-volt battery, this is always the funny thing when it happens in the OR though, right? You have all this, thousands of expensive equipment, then you go get the wand out and the 9 volts dead, you're going, okay, where do we find a 9-volt battery in the operating room? It's like drives everyone nuts. It's like, okay, you gotta be kidding. So that's probably the most important place to think about where you keep a spare 9-volt battery, because seldom do we have one, it seems, in the OR, which is the worst spot to have this happen. All right, and then the package insert is there. So I think I'm gonna stop there. Do we have, before we go to the cases, do we have dosing questions? And then
just like overview. So you keep up by going on the app output after you fix the pulse width and the frequency.
So when I start
1.5 and then you stay for 6 months, that's my understanding.
Yeah, I would give them a period of time there. I mean, I literally, the day that I turn the device on, I'm at 20 hertz and 250. So I take the standard ones and change them, immediately. And then there'll be a 0.25, for example, when they first start, where you kind of ramp up. Like I said, most adolescents and adults, I'd like my minimum to be kind of 1.5, so I'd like to get them between 1.5 and 2 if they're tolerating 1.5, and I've seen seizure improvement as I've gone up. I mean, I'll go to 1.75 or 2. But, if they're doing great and they're at 1.25 or 1.5, I'll leave them there. So just like medicine, a lot depends on the response you're seeing.
But if at 1.5 you still have seizures, I mean, you still go up to what the...
I'd probably go up to, in an adult, most of them will tolerate you going up to probably 2, maybe occasionally 2.25. I'm not sure I'd go higher than that. In kids, especially the younger kids, like below age 5 or 6, a lot of, I probably would go up to at least 2.5 before I'd say, okay, there's no point in going higher. Does that make sense?
Yeah, I mean, just like, I understand. So 1.5 and wait, even if they don't have response, or?
No, I would go up. Yeah, if they're
You're
tolerating.
continuing up until?
Longer tolerate. In adult, I would go to like,
response, or reach 2.
probably 2 for adults, probably 2.5 the young kids, yeah. Yeah, unless I'm getting a response prior to that, yeah.
It's supposed to mean 50% reduction or free of seizures.
I'm seldom gonna get free of seizures, right? Because across all the studies, seizure-free rates with VNS are about the same as you would expect for any medicine. They're about, 5-6%. So, I mean, occasionally patients will ask me that, can I be seizure-free? And I tell them, I said, most patients know that's not what I would expect. It's only about 1 in 16 to 1 in 17, that become seizure-free. So if it happens, obviously that's great, but that's not the norm. So yeah, usually I'm looking at, other factors to say, have they had improvements? So are the seizures decreasing in number? A lot of patients, we see the intensity decrease, so they may be having, say, partial seizures that frequently secondarily generalize before VNS, and afterwards they aren't secondarily generalizing at all. They might have the partial phase, but none of them go on to secondary generalization. So it's a big improvement, but their numbers may not be that, different, if you will. But the seizures are very different. So, I mean, you kind of, look at all those things to make a decision, yeah.
Which clinical scenarios will tell me I have to go for the on and off change rather than
Yeah.
the output?
So work with your output first, that's easy. Stick with your output, that's where you get your most bang for your buck. Okay, so I would go up on that, and then like I said, I probably would sit there until at least out 9 months or a year, once I've got that up, kind of see how they're doing. If I'm out that far, and the seizures are not as improved as I would like, or the patient would like, that's when I start to look at the duty cycle, but I seldom do it before 9 months or a year. What, is that with your experience?
That's true.
Yeah, because I'm trying not to change the meds, and I'm just trying to kind of ramp up that, that. And like I said, I have a patient that we kept locally recently, a couple months ago. I was telling him when I got here, but he was from, several states away, so he stayed around. We ramped him up to 1.5, and when we first saw him, he was having daily convulsive seizures, a 12-year-old. And he's only about 2.5, 3 months out now, but the family called and said, now he's down to the first month. He went home, and he was at 1.5 when he left. Right after a week, we went really quick. He tolerated, which was good. But he went down to a couple a week, and then he had a couple of weeks in there where he was having no seizures. Not seizure-free, still has intermittent ones, but I mean, this dramatic improvement when you're having one every day, so.
I have a question about magnet abuse.
Right, magnet abuse, yes.
Because here in the culture, sometimes the housemaid has to look after the child.
Right.
They just teach her whenever he has a seizure, just swallow
Right.
it, and we find it in the history.
Yeah, so that's the reason to set the magnet really low, the time. And so somebody like that, you might want to set the magnet for 7 seconds, because then he won't use up all the battery. So you could set it for literally 7 seconds. Yeah, setting, and I probably would do it in somebody like that. I'd probably put the magnet really short. Because we have occasionally that in the States, that parents will do it, and I ask them, I say, well, is it working? And they say, it's working. And some of the things it's working for sound like seizures, but some of the things sound like behavior. And they say, oh, it's better after swiping. Okay, I guess this is like, behavior modification for your kid. Instead of hitting them, you're swiping them, but if it works, I guess it works, so. But yeah, so I would set my magnet very short time if I had somebody doing that, I think.
Can I emphasize a few points here? One of them is dosing is a very crucial issue here, and it's how we feel comfortable with the device versus uncomfortable, and it really dictates the outcome, particularly if misdosed or underdosed. And the problem that encounters many of us is that particularly in centers where there's multiple neurologists, etc., then dosing may be a little bit variable from individual to individual. We tried in our center to overcome this problem is to have a single person do the dosing, probably a nurse practitioner, etc., under the supervision of one of the physicians, and then you can actually have that person trained to do it, ramp up the dose, treat most of the pitfalls that would usually encounter, etc., and be very familiar and have her or his contact accessible to the patient or his number. And therefore, you would kind of guarantee a standard. and you can look at the overall picture and assess. Your decisions would not be sort of reactive, it would be more of a steady decision based on time and based
No,
on.
I agree, I think that's a good idea, and what we kind of do, and you probably do too, we kind of have a flow sheet for each patient, and so with columns, so you can write down all these parameters, so you can look and see that was, this day I was 0.25, and the only thing we changed, went to 0.5 this day, 0.75, so you can look across one sheet of paper and see, like literally a couple, 7 or 8 visits and say, okay, this is the only change, you can kind of do that, 'cause it's very hard to look back through charts or remember or, kind of pull up the history, so it's a lot easier if you kind of have a flow sheet to say, okay, this is the only thing we're changing, then other people can look at it too, if you're out of work or you're here at a conference, and say, okay, he was going up, and a lot of times in my notes, I'll even mention it, so if I'm not there and my nurse practitioner's doing it, I'll say that, okay, as long as the patient's tolerated, the next visit, we're gonna go from, 1.5 to 1.75 milliamps, so everybody's kind of on the same plan, yeah, I agree.
The problem in practice, you get your dose up to like 2.5 and you want to sit it there and wait for a few months and then you go on vacation, somebody
Messes it
the
up,
patient comes out with brief seizures or seizures.
so you can't go on vacation.
And they go, so the communication definitely helps if you put your plan clear, but
Yeah.
it's also kind of like difficult to judge with the knowledge that there's clinical efficacy with the device over time, and then when to judge it, that, okay, I got enough wait time that I should not push the envelope more, so you can, because we sometimes go up to, in kids, 3.25
Yeah, I think-
or 3.
I think the key, that's a good point. I think the thing I would say is, there is this late response, and we've talked about that, but most of the response from VNS is not from the late response, it's from what you're doing with your dosing. So I tell families, I say, we may not have your best response in the first 6 months, but we'll know whether you responded all or not. Because I should see some response, even if it's not your best response, as I go up, I should see some improvement in seizures, whether it's number, duration, intensity, there should be some change there. And if the family sees it, obviously that's what's encouraging them too, is that, okay, we're not, it's, perfect by any means, but at least we're seeing things, continue to improve. There's that steady improvement over time as I'm going kind of up on the dosing. And then if they get a late response, again, I tell them it's like icing on the cake. If we sit here and you see some improvement over time, wonderful, that's great, but we're not kind of waiting for that to see if the device works. We know kind of before that hits. That's a very good
It's
point.
not easy to relate this to the family sometimes, because you get the pressure, it's like, okay, he's having more seizures, what are you gonna do now? You're gonna wait and just tell me
Right.
this, thing that this.
Yeah, and again, as we said earlier,
One action right away.
yeah, I mean, we use the device kind of with drugs, so sometimes we'll, tell the family, like, okay, the device is, you're seeing these positive changes, let's maybe refigure, if we're out far enough, we don't do it in the first months or so, obviously, but if we're out far enough, like you said, so he's at 2.25, or where we may say, okay, maybe we should think, step back and think about the medicines and see what we should do. So there's, you can always make changes, they don't always have to be, just the device ones, obviously, depending, where you are in your treatment sequence. Yeah. All right, I think, well, hey, we'll do one
Just
more
like
quick
the,
cases here.
I think a scenario where you go beyond that 2.25 to like 3.5, which is the maximum.
Right.
When do you like go for that?
Like I said, many, many years ago, we first started, we did that, people tolerated it. In recent years, I haven't done that at all. It just hasn't come up. I guess the only time I would do it is if I was, again, it would probably only be a young child, because you can't ever get adults there, they just don't tolerate it. They're having too much problems, local changes. Is if I had a kid that I was seeing steady improvement, something was getting, better, every time I went up, okay, we're at 2.5, 2.7. I might push him a little bit. I don't know that I would go to 3.5 though nowadays, because it doesn't make sense from what we know about kind of activating the nerve. It had to be, unusual case. And I had to do it
How
years
did
now.
contrast the 3.5 and 3 minutes BD cycles, how long does the battery last?
With a 105, even the high capacity, if you had a high duty cycle at 3.5, you'd probably be down 2.5, 3 years somewhere, I'm guessing. So not short, but compared to, if you were at, 175 or 2 with the 30 seconds, 5 minutes off, 250, 20, you should have 8 to 10 year battery, as well.
Yes,
Yeah,
it's
it's a big difference. So, all right, let me see. Are you doing your case? Who's doing case next?
Yeah, I got it.
Oh, he's getting you. Sorry. Greg woke up.
Uh,
He was sleeping in the back. I didn't see him.